Welcome to the Real GI Doc Show. I'm your host, Dr. Fred Gandolfo, and I'm a board-certified gastroenterologist with a medical practice in New York. Today, I'm going to be tackling another listener question, and this one is interesting. It's about GLP-1 drugs. So these are drugs like Ozempic. You've heard of Mounjaro. These drugs are all over the place right now. They're all over the news, and you probably are taking one or know someone who's taking one. And today's question comes from a listener who's concerned about the effects of these drugs with a specific medical condition called inflammatory bowel disease. Crohn's disease, ulcerative colitis, these are both types of inflammatory bowel disease you may have heard of. And I'm going to play the question and then do my best to answer it. So let's listen to our question. I have it here from Jennifer.
Hi, my name is Jennifer, and I have a question about the use of the GLP-1 drugs for people who have bowel diseases like colitis or Crohn's, etc., or even patients like my husband who no longer have a colon after having had it removed because of ulcerative colitis. And I'm just wondering if there's any data yet that shows these drugs can actually be helpful for those patients to both lose weight and also slow down the transit time of food. Thank you.
Okay, so that's a great question, and we're going to try to answer it. But of course, I've got to give a little bit of background here. So these drugs, these GLP-1 agonist drugs, you may know them as Ozempic, Wegovy, semaglutide or semaglutide, depending on how you say it, Mounjaro, Zepbound, tirzepatide. These are the popular ones. There's older ones that were given for weight loss and diabetes in the past, and some of those drugs are still out there. But basically, these are all the rage now, mainly for weight loss, but they've been used for diabetes for years. And what is GLP-1 is the big question, or my big question today. And it's called glucagon-like peptide. So GLP-1 is glucagon-like peptide, but we're going to call it GLP-1, and we're going to call the drugs that you give to use for weight loss, we're going to call them GLP-1 agonists. Now, an agonist is a drug that you give that stimulates something to happen. So an antagonist, people know of antagonists as drugs that block stuff. That's usually like we give Pepcid to block histamine in the stomach. Therefore, you don't make stomach acid. That's a H2 receptor antagonist. GLP-1 drugs, these are agonists. These actually bind to the receptor for GLP-1 that's naturally in the body, and they stimulate the effect of GLP-1 as if the GLP-1 levels are higher in your body. So we're going to call these drugs just GLP-1s, but just know that they're stimulating GLP-1, and that's what Ozempic and the like do. So these drugs are made in the GI tract. The GI tract has become famous in the last many years because of the microbiome and other stuff, but these GLP-1 drugs also are made in the GI tract, and they're made by these cells called EEC cells. These are enteroendocrine cells, and they secrete GLP-1 all the time. So there's a basal level of GLP-1 that's always in the body and is being secreted 24/7. When you eat, it rapidly rises, and it happens to be produced by the ileum, which is the end part of the small intestine. It's really the entire small intestine, but mainly the end part called the ileum or the terminal ileum that produces the most GLP-1. And then the colon also produces a lot of GLP-1. That's the large intestine. And GLP-1 does a bunch of things. So when it goes up in your body, what does it do? The main thing it does is it actually increases insulin secretion by your pancreas. So it stimulates the beta cells in your pancreas, which produce insulin, and it causes insulin secretion to go up. It also causes those beta cells to proliferate, to grow more of them and to increase their size. It's pretty neat. So it keeps the beta cells fed and happy, not really fed from a nutritional perspective, but it keeps them going, and it increases the insulin secretion by these cells. And then what insulin does, we know it drops the blood sugar when you eat, but GLP-1 also inhibits glucagon secretion. And glucagon's like the opposite counterbalancing hormone to insulin. Glucagon raises your blood sugar in various different ways. So when your blood sugar dips down, glucagon gets released and it keeps your blood sugar up to keep you safe. And it does that in various different ways. The overall net effect of GLP-1 is that, or in terms of like, why do we care about it? It's because it helps you lose weight, and it helps you lose weight because it decreases food intake. It does that by a couple different ways too. It alters the gut motility. So it alters the stomach emptying, it slows down the stomach emptying, and it slows down the small intestine transit. So it stops things from moving through your GI tract so rapidly, so you feel full longer. And it also causes decreased appetite in your brain. So this is pretty amazing too. So not only do you physically feel full because you are full, because the drugs are not allowing your stomach to kind of empty out as fast as it normally would, so slowing digestion, and your brain will tell you, hey, I'm full, I don't want to eat. That's all a normal pathway. But GLP-1 in the brain also contributes to feelings of satiety. And these pathways are still being worked out. But it's interesting, you actually physically feel full. And people report this as they don't feel cravings for food all day long. They don't feel this food noise, in quotes. I hear this term thrown around a lot. And I think that's just the chatter in your brain that you're hungry when you're really not in need of nutrition. You're just hungry because food tastes good. So GLP-1 drugs really do help with that. And what's the effect of the drug? When you give it to someone, like what's going to happen? If someone's obese and you want them to lose weight, how does it work with these GLP-1 drugs? The average weight loss that someone can expect if they're responding to the drug normally is about 5 to 15% of their body weight can be lost in about a year. And that's a lot of weight. So let's take some examples here. Really, we'll look at a woman who's about 5'6". She weighs about 230 pounds. That gives her a BMI, or body mass index, of 37. So that's well into the obese category. That's actually morbidly obese. That person can lose about 11 to 35 pounds in a year by taking these medicines and doing really nothing else. Pretty amazing. A 5'10" man who weighs about 280 pounds, that's a BMI of 40. So that's into the morbidly obese category also. That person can lose 14 to 42 pounds by taking these GLP-1 drugs over about a year or so. And the results may vary, of course. Some people lose no weight, some people lose a ton of weight, figuratively speaking. And it's amazing because these drugs are relatively safe. And the rest of the time, we're going to talk about these side effects. But these drugs are overall quite safe compared to the alternatives that used to be out there in the past, and compared to not doing anything and not losing the weight and having all the associated medical problems that come along with carrying around too much body weight. So the problem is with these drugs, or the effect of these drugs, not a big surprise. You have to be on them forever if you're going to keep losing the weight, or if you're going to maintain the weight loss. The effect of these drugs requires that you stay on them, just like every other drug, right? If you go on a blood pressure medicine, you don't change anything about diet and lifestyle, and you eat kind of whatever got you to that place of the high blood pressure, or you're just getting older, or whatever the mechanism is in you, and then you stop the medicine, your blood pressure just kind of goes back up to where it was. Doesn't cure high blood pressure, it just treats high blood pressure. And that's the same issue with these GLP-1 drugs. You're kind of married to them for a long time. If they're working for you and you want to stop them, you can. However, you have to expect that the weight is probably going to come right back. And the people in studies who don't regain the weight, they have to stick to a pretty strict diet and lifestyle and exercise program kind of throughout life. So they have to kind of do what they did to get there on the GLP-1 drug forever on their own. And exercise is a big part of that, and that's beyond this talk. But the people who can successfully remove themselves from these drugs and maintain most of that weight loss, it's a small percentage, but they really did intense lifestyle and exercise interventions. So that's pretty interesting too, and it goes along with a full kind of comprehensive program for weight loss. You can't just really take the drugs and expect the best effects. You have to do the other stuff too. The drugs just kind of help you get there. So that's the story. Weight regain, almost universal if you're not strictly controlling things kind of forever. You can never really let yourself slip again with obesity, unfortunately. That's just the way the body's wired. And what are the common side effects? So the listener asked a question about side effects of the drug. So the common side effects that you hear about, and this is not just inflammatory bowel disease patients, this is kind of everybody. Most of these side effects are GI as well, because that's where it affects the body. So nausea, vomiting, constipation, diarrhea, those are the top few side effects that you hear about. And a lot of people do discontinue the drug, like they stop it based on the side effects of nausea and fullness. Some people just feel sick on it. Most people learn to kind of deal with it. You titrate the drug slowly, meaning you start from a low level and you work your way up over the period of several weeks, and your body gets used to that side effect often. And usually you feel okay on it. You feel full, but you don't always feel nauseous unless you try to overeat intentionally. But some people can't take it, or the feeling is just so bad that they're basically have to stop the drug because of the nausea and sometimes vomiting side effects that happen. And when these drugs initially came out, because they work on the pancreas, there was a lot of concern about pancreatitis or inflammation in the pancreas. And that's been looked at, and sometimes they do find people on these medicines get pancreatitis, but it doesn't seem like it's increased from the risk of pancreatitis from just being diabetic or just being overweight in general. Those are both issues that are associated with having pancreatitis, and the studies really now don't bear out that these drugs cause pancreatitis. So they should be safe for the pancreas. It seems like they are. Any drugs that cause rapid weight loss, including bariatric surgery, weight loss surgery, even diet, exercise, routines that will cause weight loss, they can cause gallstones to happen because of various reasons. But so gallstones are increased in some people who take these GLP-1 drugs. The other things that can happen, immune reactions, just general intolerances, rashes, strange one-off side effects. Of course, that kind of stuff can happen whenever you're taking a drug, but it seems to be pretty low risk. And liver issues, kidney issues, skin conditions, all kinds of stuff has been reported, but these are like super rare in the users of these drugs. So if you looked up any drug side effects, even the common stuff that people take all the time, you'll find all this stuff in there in terms of side effects in the 1% range or so. And that stuff is important to know about if it's you, but it's not really like, you shouldn't be too afraid of those side effects when taking anything. Otherwise, you take nothing. So that's the common stuff for kind of everybody. And what about the bowel? Like, how does GLP-1 affect the bowel? Because it's made there and it probably does some action there. It seems to do most of its action there for weight loss. What are the side effects in the intestine or the gut in general? So GLP-1, it increases. So GLP-1 actually goes up naturally when your gut is under stress or your body's under stress. So when your body is under stress from an infection, from sepsis, from an intestinal infection, some type of bacterial infection in the gut that's causing you to get to become sick, or ischemia, it's not getting good blood flow. These things will all cause GLP-1 to go up, and that's maybe it's a protective mechanism, because the end down the line side effect, the down the line effect of the GLP-1 naturally going up in your body is that it reduces inflammation, especially in your gut. So there's been all kinds of mainly animal data, unfortunately, that shows this kind of stuff, that shows that these intraepithelial lymphocytes, which are like immune cells that are living inside your gut lining, kind of watching everything, that these intestinal intraepithelial lymphocytes are stimulated by GLP-1, and they cause a reduction in inflammation. And there's been mouse and rat or whatever animal studies that were done that show that the tight junctions between your intestinal epithelial cells can increase in strength, which is a good thing. You want your cells in your gut to stay together. You don't want to leak bacteria across in the gut lining and cause all these other potential problems, including total body inflammation and other issues. And GLP-1 seems to help that process in animal studies. And the scary thing is, I shouldn't say scary, but just the thing that you can't really generalize these animal studies to people quite yet until there's really studies done in people. And that's one of the things that is a limitation of all these great animal studies that are interesting, is that we treat people, we don't treat mice. And mice and people, although we may have similar biochemistry on a cellular level or whatnot, the research doesn't always translate from animals to people. There's a lot of things that can happen when you manipulate things. When you add a drug into a person, you're not just adding it to cells in a lab, you're adding it to an entire person. It can have all kinds of other effects too. So human studies really are needed to see if it's really a good thing for the gut or a bad thing for the gut, which is the kind of the next part of this talk, which is really what the listener asked was, hey, I have inflammatory bowel disease, or my husband has inflammatory bowel disease and he had his colon removed. What do you do here? Do you take these GLP-1 drugs if you're overweight? And how many people with inflammatory bowel disease who have a colon removed are really overweight? It's typically a condition that you see associated with people losing weight or not being able to maintain body weight because they're missing an important part of their GI tract, or that part of the GI tract is there but not functional. And so let's look at the data, basically. 15 to 40% of patients with inflammatory bowel disease are obese. So it mirrors the general population, which goes to show you that you don't need to have nourishment necessarily to be obese, because obesity is excess calories. We're eating lots of poor quality calories, really just straight up sugar calories, and you can have poor nutritional status and have obesity. It's a very interesting thing that can happen. So 40%, up to 40% of patients with inflammatory bowel disease can be obese. And let's look at some studies on those patients. So patients with inflammatory bowel disease, really, who are taking these GLP-1 drugs. So recently there was an abstract released at a major conference called DDW, and this will be linked below. And it showed that 90% of patients that were in this study of 230 patients, 90% of them actually tolerated these GLP-1 drugs just fine. And the 10% that stopped them, they stopped them because of typical stuff: nausea, vomiting, diarrhea, constipation, but not because of inflammatory bowel disease flares. They didn't require more medication. They didn't have surgery. It didn't actually affect the inflammatory bowel disease. They just stopped because they're people and they got the same side effects as all the other people in the world who didn't have inflammatory bowel disease. So that was pretty cool. I'm sure that we publish at some point in a journal, but right now it's just an abstract form. Another study that was published shows 224 patients with inflammatory bowel disease. It followed 224 patients. They started GLP-1 drugs. It followed them for about a year. And this drug was looking at the inflammatory bowel disease component of the outcomes. And it really showed that there was no increase in these people flaring. So there was no need for medications, new medications, surgery, hospitalization, steroids, etc. They basically did okay in terms of their inflammatory bowel disease, and the people who discontinued also for the same kind of idea. They just got nauseous or had diarrhea just related to the GLP-1 drugs and had to stop. So a few percent of people do discontinue the drug, but overall most people did it and they did well and they did not flare their inflammatory bowel disease. So relatively small studies, but both looking good. And they actually was a very small, like a pilot type study in colectomy patients. Because if you remember that GLP-1 is made, a lot of it's made in the colon. So if you're missing your colon, if you had really bad ulcerative colitis and your colon was removed surgically because nothing else was working or it was just too far gone by the time you got diagnosed, and you're missing part of your colon, then in theory, your body's GLP-1 production capacity might be low. You might not be able to make a lot of GLP-1. And what happens if we give people GLP-1? A lot of people who are missing their colon, they don't have normal... Pretty much nobody anybody who's missing their colon does not have normal bowel function after that, by definition. And a lot of people can manage it, and they have several bowel movements a day, 6 bowel movements a day or so, and that's okay. Some people have a high output forever, like they have constant high output. They're missing their colon. They're constantly going to the bathroom 12 plus times a day. In this study, it took people who were going to the bathroom, I think around 12 times a day and having bowel movements 12 times a day after they had colectomy surgery. And some of these people had reconstruction in terms of having a J pouch, but some of them did not have a reconstruction. They had an ileostomy. And out of those people, there were only 8 people in the study. But out of those people, they gave them GLP-1 drugs, not because they were obese or overweight or because of diabetes, but they gave them GLP-1 drugs to see if they can slow down their output. Will GLP-1 drugs actually be beneficial for these patients with no colon? And it turns out it was. Actually, it reduced the bowel frequency or decreased the bowel frequency by 35%. So on average, if they were going to the bathroom 12 times a day, which can really be, all you do all day is going to the bathroom all day. If you're going 12 times a day for life, that brought that down by 35%. So that's a huge reduction in the bowel movements. And in theory, that's because it slows down the gut. It slows down digestion. Maybe it reduces the calorie intake a little bit. So that also gives your gut a rest, but it may have other effects. So pretty cool. And this is just one small pilot study of only 8 patients. One person had to stop the drug due to side effects of nausea. And the study was supposed to be bigger, but apparently they had trouble just sourcing the drug for the study. These drugs are hard to get, and I guess there was an issue with the supply for the study, and just like everybody else can't get the drug, the study people couldn't get the drug, and they had to kind of stop a little earlier. But hopefully one day that there'll be enough of this stuff around that people with colectomies, if it works this works really well, maybe one day we'll be able to give this as a drug for people with colectomies, or maybe we'll be able to kind of tailor it just so it causes the side effects of the drug. It doesn't cause the weight loss, because they may not all want the weight loss. So interesting stuff, but overall seems to be safe for people with inflammatory bowel disease and with people with colectomies from the very limited data here. My own personal experience in the office, seeing people who are on GLP-1 drugs, which are lots of people, lots of people out there who are on these GLP-1 drugs, I see that it seems okay. I don't really see people coming in with a lot of inflammatory bowel disease related concerns with it. If anything, in theoretical, these animal models, it might actually be beneficial. And in some small human studies like we just talked about, it might also be beneficial there too for inflammatory bowel disease for various different mechanisms in terms of reducing inflammation and reducing overall motility of the gut, especially if you're a colectomy patient and you don't have a colon, you're having lots of output, it may be helpful. So again, this stuff is all in the very early stages. It's very hard to draw strong conclusions from this. But that being said, if you're thinking of going on a GLP-1 drug and you're overweight or obese and you think it would really help you, it's something to talk to your doctor about who's going to be prescribing the drug. All these things really are not going to be as cut and dry as I'm presenting it here. You really have to talk to your doctor who's prescribing. That's your individual to talk about your individual risks, your individual benefits. And that's the important thing, is really just having an honest conversation with your doctor and, knowing that these things are probably safe overall and you may have side effects, but most people seem to do okay. And that's really a decision that you have to make with your own personal physician. That's it. So that's the story here. Thank you for the great question. And hopefully we'll hear more about the GLP-1 drugs in the future with respect to inflammatory bowel disease. Hopefully you like this episode. If you're listening to this in your car, this was our second video episode. You can find it on YouTube. I'll put a link below to the episode. I did this thing without any editing, which is pretty cool. So you'll hear a couple of little misspeaks there, and that's fine by me. That's the new style. I'm getting it done quick, and it's going to be on video, so even better. And the studio's coming along. My lighting's looking a little better. I got a little reflector action going on over here, if you can see it. This way I can fill in the side of my face here. Taking it back to my old photography roots, learning about lighting and all that stuff for video. It's kind of the same. It's just like, a learning curve. So it will get better and better. And that's really the story. So thank you for listening to the show. And if you like this and you think this show is going in a good direction, please, what you can do to help out is you can leave a review on Apple Podcasts. You can go on there and you can leave a nice review, but you can also leave a comment. It can be 5 words, great podcast, whatever you want to put. But it really does help people finding the show who would not otherwise find it. And I sometimes feel like it is, there's so many health podcasts out there, and not a lot of them are by actual doctors. So I really do want the show to get some viewers out there to help combat some of the misinformation that's out there and maybe give a more balanced perspective from a practicing physician. So that's the story. If you can do that, that would be great. And if you can't do that, that's fine too. Just listen to the show and hopefully you get something out of it and it helps you make some decisions or learn a little more about some interesting GI topics. Anyway, you can also follow the show. You can find the show on social media. The handle, is that a word anymore? I don't even know. I think, whatever. It's called @RealGIDoc on basically all the social media platforms, RealGIDoc. I'll put a link below as well. And if you'd like to leave an audio question for me to answer in a future episode, that would also be great. You can leave it by following the link in the show notes, or you can go to realgidoc.com and you'll find the link there to leave a nice audio question and hopefully get a good conversation going for another episode in the future. The last thing here about the studio space, it's almost completed. It is basically just a crappy room that I painted 2 walls of and stuck some lights in, but it's gonna work for now. And I have a second little station next to me that you can't see right now, and hopefully we'll get some guests in here, because now I have I don't want to call it a respectable space, because it's definitely not respectable space, but it is a space that we can record a show in and actually sit and talk, which will be pretty cool. So hopefully you'll see some guests coming up on the show soon. And the next thing I got to tackle is dealing with these echoes in here. So I got nothing in this room right now. I got to put some stuff in here to take up some of the echoes that are floating around. So hopefully you don't mind that. And that is enough rambling from me. I can talk all day, and luckily I will not. So see you next week. Take care.
That's it for this episode of The Real GI Doc Show. Make sure to join Dr. Gandolfo next time to explore another interesting topic in gastrointestinal health. And remember, the views and opinions presented in today's episode are for informational and entertainment purposes only. Nothing discussed in this episode should be considered or used as a substitute for medical advice, diagnosis, or treatment. If you're experiencing a health issue, please consult with a doctor or a medical provider in your area. Thanks again for listening to the show.